Welcome back, dear students. Your study partner. Yes, even I hope that you are having a great day. Dr. Kaushal, Saman, Piyush, good evening. Good evening to you all. Welcome back to this FMGE Flashback, which is trying to focus upon the previously asked MCQs in your FMGE exam, with the hope that whatever topics we are discussing will be repeated in the next coming FMGE exam. Anatomy is supposed to be taken care of in 2 sessions. One session is already over. This is part 2. And as you may be knowing, this is supposed to be a 2-hour session, 5 to 7. And we'll try to finish it off by 7. Yes, good evening. Dr. Shaval, Piyush, Arjun, Ramkumar, Vinod. Yes, it's a pleasure. It's a pleasure. It is our duty to take care of you students so that you become good doctors, and if in future we need doctors, then you are there dependent, like we will be dependent upon you. So we want you to be sturdy in your learning, and that's what we do, isn't it? Fearless, already fearless, good. So Sarkar, fearless, Sharik, Shalini, it's a pleasure to serve you. So let us continue, and as we are now moving on, taking care of some of the MCQs which already have been asked to you in the FMGE exam. You see, they are asking for identifying the arrow marked chamber. It is FMGE December 2021 question, and as you can see, always look at the options also. 4 chambers of the heart have been mentioned. So it is understood that they are focusing upon the heart and asking which chamber is there. This is a radiograph, most probably CT scan or could be MRI as well, but CT scan are most often given in the thorax region, and you just have to find out some details. You will see that anteriorly this is the sternum bone, and articulating with the sternum bone will be the ribs, anterior thoracic wall. Then posteriorly you have the vertebra, thoracic vertebra, and you can see the ribs are articulating there as well. A question comes to you, they are asking the rib articulating with the vertebra is which type of joint, and it is plain synovial joint. The costovertebral joints are plain synovial joint. Synovial joint because you need free movement so that the lungs can expand properly. So where are the lungs? Since you are looking from inferior to superior, most of the CT scans are viewed, it is a convention, you have to look from inferior to superior. So if it is inferior to superior, then this must be the right lung. This shadow, the dark shadow, and that is the left lung. You can see the heart is more towards the left side. So if this is the mediastinum where you have the heart is more towards the left side. Plus the heart will have 4 chambers. We'll look at the details, but then you can see this is one of the chamber, this is another chamber, there is one here, and total 4 chambers. The chamber which is towards the anterior side, the sternocostal surface of the heart. Sternocostal surface of the heart, mostly it is right ventricle. So you can mention here that this is going to be the, let us take a darker color, the right ventricle. Now if it is right ventricle sternocostal surface, the chamber which is posterior most in the heart is left atrium. So this is the left atrium. In fact, the examiner is asking you for the left atrium only. Choice number B should be the answer, but not like this. I'll give you some more details. If this is the left atrium most posterior, that is right ventricle most anterior, what about the other chambers? See, towards the right lung must be the right atrium. So let us change the color, and you can say this is right atrium, some darker color. So if this is the right atrium, which chamber is left? Left ventricle. So this is left ventricle. If this is left ventricle, what is this? This is interventricular septum, right ventricle, left ventricle. So just for the purpose of orientation, let us look at more details now. As you proceed, and you already have answered, Left atrium, yes. Okay, so as we go on to the details, let us first look from the front view. As you are looking from the front view, I already have mentioned, if we are talking about the heart, heart is more towards the left side embryologically, and this is the view. Now, as you look from the front view, sternocostal surface, mostly it is right ventricle. So this is, as you see, right ventricle, this is right ventricle, but partly left ventricle as marked here. And between the two you will have what is called as interventricular septum. So two ventricles can be seen from the front, right ventricle, left ventricle, but mostly it is right ventricle. What about the left atrium? You cannot see left atrium from the front view because most of it lies posterior. Then what about the right atrium? Right atrium is here. So this is the right atrium, which we can put some other color, maybe white. So this is the right atrium, front view. Now let us look from this view. You are putting a patient in CT scan and you are taking a, this is the view we are talking about, the transverse section view and inferior to superior. When you look from inferior to superior, that view will be shown here, and this will be right-sided chambers, that will be left-sided chambers. You can draw yourself, say this is, you are looking at the patient from inferior to superior, 4 chambers of the heart, and you should know this will be right atrium, right ventricle. And then you have left atrium and left ventricle, 4 chambers of the heart. But during development, the heart has rotated slightly to the left and inferior. It has rotated slightly to the left and inferior. That is why this kind of orientation will come. Let us zoom this little bit so that it becomes better for you. And as we continue with the discussion, you can see for yourself. See, as I am telling, right atrium is here. This is the diagram we are looking at. This is the right atrium. Now, if this is the right atrium, what about the right ventricle? That will be right ventricle. So this is the right ventricle. Now, we have shown the 2 chambers which are right-sided. What about the left-sided? Left-sided, we already have mentioned, left atrium is quite posterior, as you represent entire heart in a transverse section, and of course this will be the left ventricle. So left chambers, as you see, they are slightly posterior, relatively posterior, left atrium and left ventricle. With that orientation, you can now move on to the diagram which was given to you. So as we do that, you see, this could be one radiographic picture given to you, or sometime they might be giving you what is a dissected specimen. So I have given you both of them. See, this is front view, this is a transverse section. Our question is on a transverse section. So let us represent these 4 chambers in this diagram once again. As you will see, this is going to be the right atrium. Let us take a darker color, right atrium. And this is going to be the right ventricle. So that is right ventricle. Related to the sternum and the ribs is right ventricle, and this is the right atrium. Anterior chambers, as you can see, right atrium, right ventricle, and more posteriorly you have to show the left chamber. So this is the left atrium. You also should know that the left atrium is the posterior most, and when you do transesophageal echocardiography, the first chamber which you look at is left atrium. See, esophagus will be somewhere here. If you want to find out, here is the esophagus. Let us take other color. This is esophagus. So if you are putting a probe into esophagus, which is the first chamber you see? This chamber. And what is this chamber? This chamber is the darker color, left atrium. Now if this is left atrium, which you are showing here, what about the other chambers? You can see right atrium, right ventricle, so you can demarcate them, right atrium and right ventricle. What about the left ventricle then? Left ventricle, let us change the color. Let us use maybe this color. So as you are looking at the left ventricle, this is the left ventricle. You can see one more thing, the thickness of the ventricle on the left side is much more, actually 3 times thicker than the ventricle which is right. So right ventricle, if you compare the thickness of the wall with the left ventricle, the ratio is 3:1. Because the left ventricle has to push the blood throughout the body, systemic circulation, whereas the right ventricle pushes the blood only till lungs, pulmonary circulation. So this left ventricle has a thicker wall for more propulsive activity. Once you have this kind of orientation, sometime they'll ask you, what is this vessel here? So can you answer in the chat, what will be this vessel here? First of all, it is to the left side of midline. It is to the left side of midline. And second, it is running posterior to the heart. So what do you think? Because already it is one FMGE question. Deepu Singh, you want me to use English? The issue is, some students, they don't understand English. So I have to continue. देखो, पढ़ाने को हम इंग्लिश में पढ़ा सकते हैं, कोई हमें परेशानी नहीं होती, मगर हमारे स्टूडेंट्स हमने देखा है कि कई ऐसे हैं जो नहीं समझ पाते इंग्लिश, इसीलिए हम इंग्लिश में पढ़ाते हैं. Descending aorta, yes, descending thoracic aorta, descending thoracic aorta, very correct. So we have to understand that this is going to be the descending thoracic aorta, identified by the fact that it is slightly to the left side of midline and running posterior to the heart. So I hope this will help you little bit in the next coming questions, because we are expecting such questions again in your FMGE exam. Now I have taken one question from upper limb and we'll continue with that. I'm sorry, cannot continue our discussion in English, because there are some students who have difficulty understanding English, and my English is more of English. I feel that I don't speak British type of English, that it is difficult to understand. Just try to cope up with that. Okay, so you are giving the answer. Dr. Priyanka has already, sir, will there be FMGE in this year? Yeah, there is FMGE in the month of July. Already the date has come, 31st July, I believe. What is the date? I have put that in my calendar also. Your exam is on 30th July this year. Why do you have any confusion regarding that? But then we are not very sure about the December or next year January, because they are trying to include your pattern into next pattern. So I am not very sure, but this exam in July, on July 30th, it is there. Okay, so as we continue with this discussion, the examiner is asking us to identify the bony landmark, FMGE August 2020, and you can see the options. Always read the options, and as you go through the options, you will find they are radial head, medial epicondyle, lateral epicondyle, capitulum. So something which relates with the humerus as such. Now if it is the humerus they are pointing towards, let me zoom this little bit here. If they are doing so, then what exactly are we looking at? It is basically, as you can see, a bone which is up here. So let us choose some color, maybe this color. So this is, let us take this is one bone which you can see coming from up, and this is the humerus bone. Then you have one bone here, and this is a radius bone, and then you have another bone which we can take another color, which is ulna bone. So basically elbow joint. Now when we are talking about the elbow joint, Elbow joint is a hinge type of synovial joint having 3 bones articulating, though mostly it is humero-ulnar joint, but there is a participation by radius also. So radius bone, ulna is towards the medial side, radius is towards the radial or lateral side, and superiorly it is the humerus. So this is the orientation. Before we answer the question, let me take you to this diagram. It will be better for orientation. Basically, we are focusing upon right-sided elbow joint. You have to understand, we are focusing upon right-sided elbow joint, and then I can zoom a little bit. As we are zooming this diagram a bit more, you can understand we are basically talking about upper bone, which is the humerus bone. This is the humerus bone. Here also you can see this is the humerus bone here, and the marker was on capitulum, like a cap on the head of radius. So this is the capitulum. It will have a trochlea also, which is marked here, trochlea, and these are basically the condyles of humerus. So as you see, this is humerus, and let me mark the capitulum here. Capitulum is the lateral condyle of the humerus. So humerus has a lateral condyle, it has a medial condyle also, and as you talk about that medial condyle, let us change the color. This is the medial condyle, which is also called as trochlea, which is pulley shape. So this is the trochlea, which is pulley shape here. Lateral condyle and medial condyle. There also you can show this is the medial condyle here, which will be trochlea, and then you have the lateral condyle, which we are calling as capitulum. Your question was on capitulum. It's like a cap on the head of the radius. So this is the radius bone now. As you look at the radius bone, let us use some other color. Say this is the head of the radius. Maybe this color. So this is the head of the radius, this is the radius bone, and sitting on the head of radius is the lateral condyle, which is also called as capitulum, like a cap on the head of the radius. This is the head of the radius bone here. Now once you have talked about the lateral condyle or capitulum on the head of the radius, what about the medial condyle? Medial condyle is the trochlea, and it is fitting into trochlear notch of ulna, which we can use some other color. Maybe we will use this color. So this is the trochlear notch on the ulna bone, and the same you can show here also. Now because it is a radiograph, you cannot see the olecranon process, but there will be one olecranon process also, which will be going posterior. This is front view. I am not commenting upon olecranon process here. So where is the capsule? You can see there is a capsule which is connecting humerus bone with the radius bone, humerus bone with the ulna bone, so that it is having a synovial cavity, synovial fluid. In this elbow joint, where 3 bones are articulating, mostly it is humero-ulnar joint plus additional contribution by radius. There is a superior radio-ulnar joint also included. So this is where you have, let us change some color, superior radio-ulnar joint, and that superior radio-ulnar joint is pivot synovial joint. So a question can come, elbow joint is which type of synovial joint? Hinge joint. And what about the superior radio-ulnar joint? Superior radio-ulnar joint is a pivot, P-I-V-O-T, pivot synovial joint. What is the movement happening at the superior radio-ulnar joint? That is the supination and pronation. Supination and pronation happens at superior radio-ulnar joint. And what movement is happening at the humero-ulnar or the elbow joint? That is elbow flexion and elbow extension. Folding, flexion, unfolding, extension. So these are some of the details. With this orientation, I am hopeful there shouldn't be any problem at all to answer this question. Let me rub off the markings so that it becomes easier for you to identify what the examiner was asking us. And as you can see, I can zoom a little bit. the examiner is asking for what is called as the cap. This is the capitulum, which is lateral condyle, and if this is the lateral condyle, it is sitting on the head of the radius. So your answer is lateral condyle, which is also called capitulum, and over that you will see there is a projection. There is a projection that is called as lateral epicondyle. Similarly, on the medial side, if you have say use this color, trochlea is basically medial condyle. There will be a projection medial epicondyle, that is the medial epicondyle. Now it is important for us to identify medial epicondyle because it will help us in the next coming question. So lateral condyle, lateral epicondyle, medial condyle, medial epicondyle, you should know. And anyway, if you are asking for the answer we already have got, because it is asking for this arrow mark, we will say our answer is definitely the capitulum, lateral condyle. Now once you got your answer here, proceeding further, you see this is one question which has come in your exam 2 times. So what is it asking? It is a nerve injured arrow marked region, FMGE this year. So this year in the month of January they have asked, and where is the arrow mark? You can zoom little bit. As you are zooming this, you can see what they are marking towards. Posterior view, you can see this is the head region. So posterior view, the ear, the nail beds, because nail beds are there, posterior view, and appears to be something at the lower end of the humerus bone, and more helpful will be looking at the option. That is why we say that always look at the options. Radial nerve is injured, musculocutaneous nerve is injured, ulnar nerve is injured, median nerve is injured. So they are asking about some nerve which might be here related to the medial side of the humerus bone. So we have to find out which nerve relates to the medial side of the humerus bone. In fact, it is the ulnar nerve. So as you say, it is the ulnar nerve. Where is ulnar nerve related? It passes behind medial epicondyle of the humerus bone. And what about the radial nerve then? What about the musculocutaneous or median nerve? So we need to find some relations, and for that purpose we can actually look at this diagram. And these kind of questions are very frequently asked, not only in your FMGE exam, but also the INI-CET exam and your NEET PG exam. And as I told you, examiners, they keep picking up copy paste from other exams as well. So you should have some good details regarding this topic. And what we want to talk about is, as you can see, this is going to be the right humerus. We are focusing upon right sided humerus. This is right sided humerus. How do you know it is right sided humerus? Because what I find is that this is the head of the humerus, and then we have the medial epicondyle. So this is medial epicondyle over what is called as the condyle, or trochlea. This is the trochlea. So if this is the trochlea or medial condyle, over that is the medial epicondyle, which is more prominent as compared with the lateral epicondyle. So laterally we can use some other color. Say this is lateral epicondyle and this is the capitulum. So capitulum or lateral condyle, over that you have lateral epicondyle. I can zoom it little bit. So as you are doing that, now we have to find out some nerves related to it. What I am telling is, you are looking at the lower end of the humerus bone. Medially you have trochlea, which is condyle. Over that epicondyle, medial epicondyle, that is lateral condyle, the capitulum. Over that lateral epicondyle. There are some nerves related here. We have to talk about them. Passing behind medial epicondyle is the ulnar nerve, which you can see here. Passing behind the medial epicondyle is the ulnar nerve, which you can mark here. This is ulnar nerve. It is a continuation of medial cord of brachial plexus. So as you say, in the axilla we have brachial plexus, and in the brachial plexus we have medial cord. Medial cord of brachial plexus continues as ulnar nerve, and ulnar nerve will go with the ulnar bone, but before that it is passing behind medial epicondyle. In fact, you can palpate this nerve behind medial epicondyle. In leprosy it will be thickened. In leprosy it will be thickened and can result in ulnar claw hand deformity. So that is about the ulnar nerve, continuation of medial cord of brachial plexus from axilla, and running with medial bone, that is ulnar bone, that is why the name of nerve is ulnar nerve. Can be thickened. If you want to feel it, feel behind medial epicondyle. And if it is compromised, say fracture medial epicondyle, if you have a fracture medial epicondyle, then there can be ulnar nerve injury leading to ulnar claw hand deformity, which we will be looking at shortly. What about the lateral condyle or epicondyle? Laterally you have got another nerve, and as you will see, this nerve is radial nerve, and radial nerve is passing anterior to the lateral epicondyle. If there is a fracture of lateral epicondyle, the nerve which can be compromised will be the radial nerve. So this is radial nerve, and radial nerve is a continuation of posterior cord of brachial plexus. So it is the posterior cord of brachial plexus which will continue as the radial nerve, which is passing anterior to the lateral epicondyle. Fracture lateral epicondyle, radial nerve injury. Fracture medial epicondyle, ulnar nerve injury. What about the other details? As you zoom out, you have to understand that posterior cord of brachial plexus gives several branches, and the posterior cord of brachial plexus not only gave you the radial nerve, which we have shown here. Posterior cord of brachial plexus not only gave you the radial nerve, which is passing behind the humerus bone in the radial groove. The posterior cord continues, posterior cord in the axilla continues as radial nerve, passes behind the humerus in the radial groove, and then comes in front of lateral condyle, epicondyle. Since the radial nerve is passing behind the bone humerus, if there is a fracture mid-shaft humerus, then you will find the radial nerve can be damaged. And if radial nerve is damaged, what will happen? If radial nerve is damaged in fracture mid-shaft humerus, or if it is damaged fracture lateral epicondyle, then the nerve supplying extensors, they will not be working. Extensor muscles will not be working, resulting in wrist drop. So there will be a wrist drop. If ulnar nerve is compromised, then it is ulnar claw hand. If radial nerve is damaged, wrist drop. Inability to do wrist extension, because wrist extensors, they are supplied by radial nerve not working, extensors not working, there will be a wrist drop. Posterior cord gives one more branch, which is shown here, and as you can see, that is the axillary nerve. So axillary nerve is also coming from the posterior cord of brachial plexus in the axilla, and it is passing posterior to the humerus bone. As the axillary nerve is passing posterior to the humerus bone, it comes anterior. And this location is surgical neck of humerus. So what will happen if I have a fracture? If I have a fracture at the surgical neck of humerus, a case where you have fracture on the surgical neck of humerus, there will be injury of axillary nerve and paralysis of deltoid muscle, teres minor muscle. So if there is a fracture surgical neck of humerus, injury of the axillary nerve, there will be paralysis of deltoid muscle, teres minor. Deltoid is a powerful abductor, so there will be difficulty in shoulder abduction, and teres minor is a lateral rotator. Teres minor muscle is a lateral rotator, so difficulty abduction at shoulder joint and lateral rotation at shoulder joint. There will be a problem if there is a fracture surgical neck of humerus. If there is a fracture mid-shaft humerus, radial nerve injured, fracture lateral epicondyle, radial nerve injured resulting in wrist drop, and if there is a fracture of the medial epicondyle, ulnar nerve is damaged. Now tell me which nerves are content of cubital fossa? Which nerves are content of cubital fossa in the chat? Cubital fossa is present in front of the elbow joint. So which nerves are, when will be the 5 RR notes available? Very shortly. Why not? Tardy ulnar nerve, sir. Tardy ulnar nerve, if you are telling, tardy means delayed, older. It can happen if there is a malunion. So if you are asking about tardy ulnar nerve, tardy is old or delayed. So if there is a fracture medial epicondyle, there can be, this deformity is what is called cubitus valgus and all that, cubitus varus, I think gunstock deformity and all that, then tardy ulnar nerve injury will come. Yes, I agree with that. Why anatomy made easy channel not working? Anatomy made easy channel. Which channel is that? The website. Everybody asking what are you wearing? This is called as the palm rejection glove. When you work on touch screen, you wear this so that the touch screen do not detect your palm. It is insulator basically for the touch screen. Okay, so you are telling in the cubital fossa there will be median nerve and there will be radial nerve, superficial branch of radial nerve. My point is, why ulnar nerve is not a content of cubital fossa? Ulnar nerve is not a content of cubital fossa because cubital fossa is in front of the elbow joint and ulnar nerve is not passing in front of the elbow joint. Ulnar nerve is passing behind the medial epicondyle. So ulnar nerve is not a content of the cubital fossa because cubital fossa is anterior and ulnar nerve is posterior. Then what else is anterior? It is the radial nerve, and there will be one more, median nerve. There will be one more in the midline, and that is why it is called as median nerve. So median nerve and radial nerve are content of cubital fossa but not the ulnar nerve. Okay. Now, as this was our question, I hope we already have got our answer. It was asking nerve injured at the arrow mark region. The arrow mark region is towards the medial side and maybe a nerve passing behind medial epicondyle. So that is the ulnar nerve. We have given the answer. Radial nerve, if you say, can be damaged if there is a fracture mid shaft humerus or lateral epicondyle, then it will be radial nerve. Musculocutaneous nerve do not have a relation with humerus as such. Means if there is a fracture of the humerus, it will be rare to see musculocutaneous nerve involved because related with humerus are the radial nerve, ulnar nerve and maybe median nerve also. Median nerve can be compromised. One more was there, that was the axillary nerve as shown in the diagram. But anyway, the answer here is ulnar nerve. Now related with the same topic, you should know these things. Can you tell me what are we looking at? What is this and what is this? This you already know, it is a wrist drop, and if it is a wrist drop, that means loss of dorsiflexion at the wrist joint, and wrist drop can happen because of radial nerve injury. And if there is a radial nerve injury and there is a wrist drop, you can give cock up splint to prevent the deformities till the nerve is regenerating. So that is a wrist drop, loss of dorsiflexion or extension at the wrist, and that could be radial nerve injury, and you can give a cock up splint to prevent the deformities. But what about these two? Can you tell me, let us say this is A and this is B. So in A, which nerve injury? One is claw hand. Which claw hand? One is claw hand. Which claw hand? Two is Benedict sign. Okay, first pick is ulnar nerve injury. Okay, and The second pick is Benedict injury. You mean to say median nerve injury, isn't it? So I agree with you. This is ulnar nerve injury because it is ulnar claw hand, and this is the median nerve injury, which you are telling that it is hand of benediction. How will you know that this is ulnar claw hand deformity and this is hand of benediction? They appear the same, isn't it? They are appearing the same. How will you know? First of all, ulnar claw hand is persistent. It will always be like this. So ulnar claw hand, the deformity is persistent. It will always be like that. What will be there? There will be metacarpophalangeal joint hyperextension and IP joint flexion. So as you will see, what is claw hand? You will find MCP joint hyperextension and interphalangeal joint flexion. MCP joint is in hyperextension, IP joint is in flexion. That is persistent, it does not change. This is ulnar claw hand. What about this one? Here you see, you have to tell the patient to make a fist, and then only this deformity will appear. Otherwise, you cannot detect the deformity. So this is persistent, but that is not persistent. Here you have to tell the patient, make a fist. And when the patient is making a fist, it is because this hand is there. So when the patient is making fist, he will not be able to fold these three fingers. These three fingers you cannot fold. But why? When I am trying to make a fist is like this. Why this patient is unable to make a fist? Why only these two fingers are folding and not these three fingers? Because this patient has median nerve injury. Where is median nerve injury? High, maybe around the elbow joint. So around the elbow joint there was a median nerve injury. And what happened? If median nerve is injured at around the elbow joint, you will have paralysis of lateral half of flexor digitorum profundus. So median nerve injury, which is at the level of elbow joint, you will have paralysis of the lateral half of flexor digitorum profundus, which is to fold these fingers. Since median nerve is injured, lateral half of FDP is not working, patient cannot fold this finger. That is why they are unfolded. And why this thumb is not folding? Because again, if you want to fold the thumb, you need flexor pollicis longus, and that flexor pollicis longus is supplied by the median nerve. If there is a median nerve injury here, the muscle paralyzed is flexor pollicis longus. Patient cannot fold the thumb. Patient cannot fold these two fingers properly. So whenever you will ask the patient to make a fist, you will find these three fingers are not folding because their folding is depending upon median nerve. But still, agreed that this is median nerve injury somewhere around the elbow joint. How do I know this is not ulnar claw hand? How do I know this is ulnar claw hand or not? Because in ulnar claw hand you will find there is metacarpophalangeal joint hyperextension. There will be hyperextension of the metacarpophalangeal joint. That hyperextension is not seen in median nerve injury. It will be in flexion. So MCP joint is in flexion. It is not in extension. If it is median nerve injury, the MCP joint of these fingers, the medial fingers, they will not be in hyperextension. If they are in hyperextension, ulnar claw hand. And if they are not in hyperextension, it is median nerve injury. That is one more difference. I hope it helps you. And this is a simple question now. There shouldn't be any much problem. What do you think is the answer? It is asking which of the following nerve is compromised in a lesion at the arrow mark. Arrow mark, it is fracture mid shaft humerus. It could also happen in this fracture, this fracture, that is fracture lateral epicondyle. So same nerve will be compromised, yes, radial nerve. So my only advice to the students is practice more and more of MCQs, and you have to be very careful about this. Wherever the head of the humerus is looking, that is medial, isn't it? Wherever the head of the humerus is looking, that is medial, because it has to articulate medially with the glenoid cavity of scapula, medial. If that is medial, there will be a medial epicondyle. So this is medial epicondyle. That is why this is lateral epicondyle. So you have to be careful. Something which is more prominent and towards the medial side is medial epicondyle, and on the other side, which is not very prominent, will be lateral epicondyle. Maybe you cannot appreciate the difference, so let me rub it off and zoom it a little bit, and then you will understand what I am trying to tell. And it is so much small that it is even not evident here, but the point is that this is more prominent area, the medial epicondyle, and this is less prominent area. This is a less prominent area, that is lateral epicondyle. So this is lateral epicondyle, and this is medial epicondyle, and this is posterior view. Just a second. No, this is the anterior view, or is it posterior? Just a second. You can see olecranon fossa actually, because you can see olecranon fossa. This is olecranon fossa. So this is actually posterior view. Now if you say this is posterior view, what else can suggest that this is posterior view? You will notice one thing here. Maybe it is clear to you or not, but the greater tubercle of the humerus, is more prominent posteriorly. Though this diagram is not very clear, see what I want you people to understand is, this is posterior view of humerus. How do you know? Because first of all, I can see olecranon fossa, which is on the posterior side, and I can see greater tubercle more clearly. If you look from the front view, lesser tubercle will be more clear, and there will be intertubercular groove which is evident. So lesser tubercle is more evident, and intertubercular groove which is evident. But if you look from posterior view, you will see only the greater tubercle, and there will be no lesser tubercle, and there will be no intertubercular groove also. If you are unable to see what I am telling you, I can rub it off and you can see for yourself. Here, if I zoom little bit, you cannot see any lesser tubercle, and you cannot see intertubercular groove. What you can see is only the greater tubercle. But what is the importance of telling all that? Because this is where you have the radial groove. This is where you have the radial groove. So radial groove is not anterior, radial groove is posterior. So this marking is in the radial groove. The radial groove is on the posterior side of humerus, mid shaft humerus, and radial nerve injury. This question is on radial nerve, and maybe I can show you a diagram where the front view of humerus is evident. But in this question, what is your answer? So in this question, because fracture mid shaft humerus, radial nerve should be the answer. Fracture mid shaft humerus, radial nerve running in radial groove. Can you tell me one thing? Along with the radial nerve, which artery is running in the radial groove? In the chat, tell me in the chat. Here radial nerve is running in the radial groove, but along with the radial nerve, which artery is running? The artery, see, Pradyumna is asking that what if they have put a question mark on the anterior side? Even if they put an arrow anteriorly, you are talking about fracture mid shaft humerus. So it doesn't matter, in fact, it doesn't matter. Maybe they are showing posterior, maybe they are showing anterior, because this is the place where you can have fracture mid shaft humerus. And if there is a fracture mid shaft humerus, there is radial nerve injury. Answer will remain radial nerve only. still the answer will remain radial nerve. It does not make difference whether they show anterior or posterior, they should show posterior in fact. Brachial, profunda brachial, correct, correct. So Meenakshi, you have answered correct. Anjali Thomas, yes, you have answered correct. Actually, even Pranay has answered correct, Meenakshi has answered correct. So you are well informed people, and you have to understand, like there is a brachial artery and one artery which goes deeper, and it is deep means profunda. So profunda brachial artery supplying posterior compartment of the arm. Brachial artery will supply anterior compartment of arm chiefly, and profunda brachial artery will supply posterior compartment of the arm, like triceps muscle. Triceps muscle, the profunda brachial artery. Biceps muscle, the brachial artery. I will show you the diagrams of these arteries also, because already you have got questions upon that. I just wanted you people to appreciate one thing, because it might be important for you. Yes, you see here, now you can make the difference. There should be no problem at all. Can you see one thing here? Can you see one thing here? This is anterior view. Why this is anterior view of the upper end of humerus? This is anterior view of the upper end of humerus because we can see the head of the humerus and the lesser tubercle and partly the greater tubercle, and there is a groove, intertubercular groove. So this is anterior view of the humerus because medially head and lesser tubercle and greater tubercle, and between the two intertubercular groove. You can see here, this is head of the humerus, this is lesser tubercle, this is greater tubercle, and between them this will be the intertubercular groove. So this is what I wanted you people to appreciate, because you know, sometime as a teacher we get some inner voice which is instinct, you can say, sixth sense instinct, and they help us, because that might be a question in the coming exam. That is how we teach. We are instinctive in our teaching, and those instincts are not like some God. Of course, it is God gifted, of course, but God will not gift you until you work hard. God help those who help themselves. So this inner voice will not be just inner voice, some divine thing. We work hard, we keep working on previous year questions, and automatically we'll have something in our brain, heart, mind, and tell it to you. So I am getting this a vibe kind of thing that might be helpful for you to identify humerus, whether it is anterior humerus, let us just, whether it is you are looking at the anterior side of humerus or you are looking at the posterior side of humerus. Just maybe it will help you, I do not know, it is just a gut feeling. Okay, so this is one question which came to you, and because obviously what we are doing is we are revising the previous year questions which came in your FMGE exam. This is basically FMGE 2021. Here, why the touch is not working? Just a second. Yes. So June 21, asking for the correct matching for the arterial branches in the diagram. So what are we looking at? Before you actually start thinking about the answer, you should look at the choices also, that is wisdom. So as you go through them, you see superior thoracic artery and lateral thoracic artery and subscapular artery. By looking at these names, I come to the idea that they are talking about the branches of axillary artery. Now if they are talking about the branches of axillary artery, this diagram must be related to axillary artery, an artery in the axilla, and the axillary artery gives 6 branches. It has 3 parts and it gives 6 branches. The first part give 1 branch, second part give 2 branches, third part give 3 branches, so total 6 branches. So let us revise that and then we can find our answer. What else do you see in this diagram? In this diagram, as I zoom, you will find that basically they are talking about right-sided axillary artery, right-sided axillary artery. So, clavicle bone, first rib, humerus bone, scapula bone, all those will be there. So, which bones can we make out here? Let us try to find out, and as we do that, you can see for yourself. See, this is the sternum bone. If this is the sternum bone articulating with the manubrium sternum is the first rib. So, this is going to be the first rib. Now, if this is the first rib here, lying over the first rib is clavicle, and under the clavicle you have artery, subclavian artery. Subclavian artery is in the neck region, going under clavicle, but going superior to first rib. So, the point here is, by looking at the bones only, you can make out some details. So, first rib, and superior to that will be the clavicle, and outer border of the first rib, subclavian artery will become the axillary artery. So, before that, if you look at this artery, say let us take some other color, running on the superior surface of first rib, under clavicle, running on the superior surface of first rib and under clavicle will be under clavicle artery, subclavian artery. And as the subclavian artery, so this will be the subclavian artery. As the subclavian artery passes outer border of first rib, as it crosses the outer border of first rib, it enters the axilla, become axillary artery. And this axillary artery is covered by a muscle coming from rib number 3, 4, 5, attaching to coracoid process of scapula. So, muscle coming from rib number 3, 4, 5, attaching to coracoid process of scapula, pectoralis minor. So, this is rib number 3, 4, 5, the pectoralis minor covering the artery. As the pectoralis minor muscle is covering this artery, attaching to coracoid process of scapula, that is humerus bone. This is humerus bone, this is coracoid process of scapula, which is below the lateral end of clavicle. Below the lateral end of clavicle, you have this coracoid process. If you know, there will be a ligament also, coracoclavicular ligament. Coracoclavicular ligament, which is important for weight transmission of upper limb. So, weight transmission of upper limb towards the axial skeleton, you have some ligaments like coracoclavicular ligament, coracoid process, scapula, lateral end of clavicle. Anyway, so pectoralis minor muscle is now dividing the artery into three parts: proximal to the muscle, deep to the muscle, and distal to the muscle. Proximal to the muscle, deep to the muscle, and distal to the muscle. So, first part, one branch. You can see here, this is one branch from the first part of axillary artery. Deep to muscle, you have two branches. So, deep to this muscle, you have two branches. What are those branches? One is shown here and one is shown here. So, these are two branches which are deep to the muscle. So, second part giving two branches and third part giving three branches. Third part giving three branches, one here and one anterior to humerus, one posterior to humerus. So, what are their names? The first part of axillary artery giving superior thoracic artery, and it is supplying the thorax superiorly. So, this artery which you see here is superior thoracic artery coming from first part of axillary artery, and it is supplying the thorax region. Then what is the name of this artery? This is acromiothoracic artery. Acromiothoracic artery coming from the second part of axillary artery, covered by pectoralis minor. And what is this one? This is lateral thoracic artery, and as the name are suggesting, all the three are thoracic. So, superior thoracic, acromiothoracic, lateral thoracic supply thorax. And not only they supply thorax, they also supply one gland here on the thorax, mammary gland. So, they can ask you which artery supply mammary gland. Mammary gland is supplied by the three thoracic. Which three thoracic? Superior thoracic and acromiothoracic and lateral thoracic. Do you have any other artery supplying mammary gland? Yeah, there are many. It's highly vascular. So, you know three of them. Can you add some more which will be supplying here? Yes, we will add. and let us do that. So first part, one branch, superior thoracic. Second part, two branches, acromiothoracic, lateral thoracic. What is the third part giving? Three branches. What are three branches given by third part of axillary artery? One going under scapula, so subscapular artery. One going under scapula, subscapular artery. Maybe it is going under scapula, subscapular artery, but it also supplies mammary gland. So it is also supplying mammary gland? Yes. Then which artery among these six are not supplying mammary gland? Which branches, which are six branches of axillary artery, which branches of axillary artery do not supply mammary gland? The branches which are supplying humerus anteriorly and posteriorly, they don't supply mammary gland. So what are the names? What are the names of these branches? Anterior, circumflex humeral artery, because they are going circumferentially, surgical neck of humerus, and posterior, circumflex humeral artery. So you are telling that there are anterior, posterior, circumflex humeral artery coming from the third part of axillary artery and going around the surgical neck of humerus with the axillary nerve? Yes, with the axillary nerve. So what will happen if there is a fracture surgical neck of humerus? If there is a fracture surgical neck of humerus, axillary nerve damage, and these arteries may also be damaged because they are anastomosed here. Who is anastomosing here? Anterior circumflex humeral artery, posterior circumflex humeral artery, and none of them supply mammary gland. So can you tell me the arteries which supply mammary gland? Yes. Three thoracic. Yeah, which three thoracic? Superior thoracic, acromiothoracic, lateral thoracic, and one subscapular. So you mean to say there are total 4 arteries which supply the mammary gland? No, there are more than that. There are more than. It is highly vascular. You have some more arteries which supply the mammary gland. For example, intercostal arteries also supply. Intercostal, anterior intercostal arteries. Anterior intercostal artery, they also supply mammary gland. So there are many other arteries. We are not focusing upon that. Our question is on axillary nerve. Sorry, axillary artery. Okay, sir. So what is the answer? To search for the answer, you can see for yourself because markers are given. So as you will find, let me rub it off first because it has become too crowded now. So what is marker A? Marker A is the superior thoracic artery. Now start from there only. Marker A is superior thoracic. Superior thoracic, yeah, this could be the answer. Superior thoracic, this could be the answer. So otherwise no other possible answer because marker 1 is superior thoracic artery. So you are stuck with choice 1 or choice A or choice C. Then what is marker 2? Marker 2 is lateral thoracic artery. So search for marker 2 now. Marker 2, lateral thoracic artery. This appears to be the answer. This cannot be the answer because marker 2, they are telling acromiothoracic artery. No, acromiothoracic artery is not labeled here with numbers. So you mean to say this cannot be the answer? No. So only possible answer is A. Yes. Can we check that? Yes, you can check that by looking at third. Is the third subscapular artery? And marker 3 is yes, subscapular artery going under scapula. Going under scapula, participating in scapular anastomosis. So our answer is choice number 1, like that. And some more details. Now as you are talking about the details, you will see I already have mentioned some already with you. There was one artery which was under clavicle. It was in the neck region. So in the neck region under clavicle I have subclavian artery. Clavicle, subclavian artery. Let us zoom that. And as you zoom that, you will find this is the subclavian artery. Now if this is a subclavian artery, as it will cross the outer border of first rib, as it will cross the outer border of first rib, it will enter the axilla and it will become the axillary artery. So what is the extent of axillary artery? Axillary artery is in the axilla and the extent is that it begins at the outer border of first rib. okay, but where does it end? It is the lower border of teres major, lower border of teres major muscle which attaches to humerus. So attaching to humerus there is a muscle teres major. At the lower border of teres major, it will stop, means the artery will stop. No, the naming will stop, artery will continue, but then it will be called as the brachial artery in the arm. So now it is renamed as brachial artery. Brachial artery is a content of cubital fossa, and there it will give two branches. So as you say, what is the extent of axillary artery? It comes from the outer border of first rib, because before that it is under clavicle, so subclavian artery, and reaches till the lower border of teres major. After lower border of teres major, it is brachial artery. And now you can see brachial artery giving you one profunda brachial artery. That is the profunda brachial artery which passes behind mid shaft of humerus in the radial groove with the radial nerve. So this artery which you are looking at now is profunda brachial artery, and profunda brachial artery is passing behind the bone humerus, mid shaft humerus, along with the radial nerve, and it supplies posterior arm like triceps muscle. Biceps muscle supplied by brachial artery, triceps muscle supplied by profunda brachial artery. Now what the brachial artery doing? The brachial artery, as you can see, is becoming a content of the cubital fossa. So as you say that brachial artery runs in the arm and becomes a content of cubital fossa in front of the elbow joint. You take a stethoscope and diaphragm of stethoscope here for measuring blood pressure. So if you want to measure blood pressure, the Korotkov sound, we call it as Korotkov sound. So Korotkov sound taking blood pressure is for putting your diaphragm of the stethoscope on the brachial artery, just superior to cubital fossa. So that you do. Now this brachial artery, which is a content of cubital fossa, what does it do now? It will give two branches, and as you see, let us take some other color. One follow the radial bone, so radial artery, and the other follow the ulnar bone, so ulnar artery. So in the cubital fossa you have three arteries. What are the three arteries in the cubital fossa in front of elbow joint? Brachial artery, radial artery, and ulnar artery. So what the ulnar artery will do when it enters the palm? When the ulnar artery enters the palm, it will form superficial palmar arch to supply the palm, hand. So when the ulnar artery will enter the palm, it will form superficial palmar arch. And what will the radial artery form? The radial artery, when it enters the palm, it will form the deep palmar arch, deep palmar arch. So it will be forming deep palmar arch, and these two arches in the palm, they anastomose. So as you can see, this is the radial artery, this is the radial artery. So radial artery following the radius bone form deep palmar arch in the palm, and ulnar artery forms superficial palmar arch. If you want to check the patency of ulnar artery, if you want to check the patency of ulnar artery, you do Allen test. You do Allen test. So Allen test is done to check the patency of ulnar artery. But why? Because I was taking a radial artery blood sample, and when I am taking a radial artery blood sample, there is a chance that a thrombus will form. I want to make sure ulnar artery is patent enough to supply the hand in that case. So before you take radial artery blood sample, check the patency of ulnar artery by doing Allen test. Allen test is done to check the patency of ulnar artery, so that by chance when you were doing radial artery blood sample, if a thrombus was developing, thumb will not die of ischemia, because normally thumb is being supplied by radial artery. If there is a thrombus in radial artery, thumb will die. Will the thumb die? No. Why? Because there is anastomosis between the superficial and deep palmar arch. Maybe there is a block in the radial artery, but still ulnar artery is patent enough to supply not only the little finger, middle finger, but also thumb. So you want to make sure, otherwise you cannot take this sample. So Allen test should be done before taking radial artery. You should know that ulnar artery is patent enough to even supply thumb in case of emergency. And what is that emergency? Emergency, there might be a thrombus in the radial artery. That is emergency. Okay, and I think this was a question recently, your INI-CET exam recently. Now you will say, sir, we are not giving INI-CET exam. Yeah, of course you are not giving INI-CET exam, but I told you copy paste, copy paste. Your DNB people, NBE people, they will be doing copy paste. So if possible, practice some INI-CET and NEET PG question, but not needed, in fact, not needed. Just practice your FMGE questions. Okay, I get you have got mnemonic, slap the lawyer, save the person. Okay, fantastic. This is your FMGE question, yes. This year only, this year. You see, January 2023. High chance of repeating itself. And next pattern, this is next pattern. What is next pattern? Next pattern is nothing but just creating a question by creating a hypothetical clinical case scenario. It is an anatomy question, of course, but clinical case scenario. So next question, that is the difference. In the previous question, there was no clinical case scenario, but now there is a clinical. So what is it? 7-year-old, sometimes the age is also important. Presented in emergency, elbow pain, swelling, elbow and hand, can't move, elbow, pain, numbness, hand and fingers, radial pulse is feeble, X-ray. So that is why we say that continually practice previous year question, but sometime before going through this long stem of the question, always read the options first. Start with the options only. Instead of reading the full question, go backward, read the options. Axillary artery, brachial artery, radial artery, ulnar artery. Okay, so they are asking us something about the artery. Now, what is this? Some fracture. What fracture is this? What is this? As you see, there are two bones here, which are forearm bones, and one bone here, which is because already they have mentioned elbow, so humerus. So humerus, radius ulna, yes. But it is a fracture in the humerus, supracondylar fracture, and there is a displacement also. So not only there is a supracondylar fracture, but there is some displacement of the proximal fragment, you can say, or distal fragment. Posteriorly, the distal segment has been displaced posteriorly. Anyway, you must be knowing this case. It is an orthopedics case, and the supracondylar fracture can result in damage of an artery. The artery which was related to the humerus. So which artery? Brachial artery. Brachial artery can be damaged. So if brachial artery is damaged, then what is the problem? Problem is this could be a case of Volkmann ischemic contracture. It can go into Volkmann ischemic contracture. If you are compromising brachial artery here, even the radial artery will become feeble. Radial artery will become feeble because it is a brachial artery which gives blood to the radial artery. So it's a long discussion anyway, but let me just focus upon the anatomical part here, and let me just take you to this diagram. It will give you a better view. Okay, maybe. So I will draw it myself. So the point is here, the problem what we face with is brachial, some other color, some bright color. struggling with this technology. Anyway, let us make use of this. So, this artery, which was then giving two branches. So, the fracture can compromise brachial artery. Actually, the answer is brachial artery. That is my purpose. Only purpose is we have to find our answer. Your answer is brachial artery. It is a case of supracondylar fracture. It can lead to Volkmann, ischemic contracture. That is the discussion here. And not the distal branches which are the radial and ulnar artery, but it compromises the brachial artery. You will find this diagram in Maheshwari orthopedics. Okay, so not going into much details, but it is supracondylar fracture leading to Volkmann's ischemic contracture. Radial pulse will become weaker. There will be pain and swelling around the fracture area. That is why she is having pain around the elbow and all that. Numbness in the hand and fingers. Because of bleeding, there can be compression, all that. Anyways, what about this question? Supracondylar fracture, anterior interosseous nerve branch of brachial. Anterior interosseous. No, please make a correction. Anterior interosseous. Okay, yes, but this is not the same case actually. It can happen. Sekhar, Karthik, you are correct. When there is a supracondylar fracture, there is a stretching of branches of the median nerve, which is anterior interosseous nerve, agree. And because anterior interosseous nerve is compromised, there can be some muscles which are compromised, like flexor pollicis longus will be compromised, but this case is asking about arteries. So, we are not focusing upon the nerves. Thoracic duct, where is thoracic duct? Okay, good. Okay, good. Very good. Fantastic. I think it is also a latest question. Which year they have asked? Oh, this year only. Yes. They are very pet questions, but was not asked in FMGE for quite long. Again they have reappeared. So, that is why what we suggest is like though normally what we will do is we will say do the last 5 year questions, but this was never asked in the last 5 years. So if you already have done last 5 year questions, increase it to 10 years. Previous year questions means you have to do as many as possible, practice as many MCQs as possible. So, I understand that they have not asked this type of question in last 5 years, but before that they were asking. So, what is this about? What are we looking at? As you can see, inferior vena cava, esophagus, thoracic duct, sympathetic trunk, somehow it gives us some idea about some structures passing through some opening, and some arrow mark is there, some opening is also there, and you can see one thing here, or actually you can see a lot of things here. The very first thing is vertebra. So, these are the vertebra. Now, if you say these are the vertebra, which vertebra are they? Other thing what you see is ribs. These are the ribs. So, if these are the ribs, this is the vertebra. What is this opening in? And you can see multiple openings also. Let me put some more details. Right crus of diaphragm, left crus of diaphragm. Right crus of diaphragm is longer than the left crus of diaphragm, because right crus of diaphragm is a skeletal muscle, it has bony origin. Diaphragm is a skeletal muscle, it has bony origin, and the right crus of diaphragm take its origin from the lumbar vertebra L1, 2, 3, and then if you are looking at the left crus of diaphragm, it will take its origin from L2, L1, 2. Between the two, you have median arcuate ligament, and basically they are asking us about the median arcuate ligament. So this is basically an opening which is bounded by the two crura of the diaphragm, and it is almost in the midline, and it is called median arcuate ligament. Which vertebra is behind that? The vertebra which is behind that is T12 vertebra. It is in front of T12 vertebra. So in front of T12 vertebra and behind the median arcuate ligament, you have which structures passing? And you remember them as ATA structure. ATA structure. Now, what is this ATA structure? There is one vein which is which color should be used now? Maybe this color, doesn't matter. So azygous vein, and then what is T for? T is thoracic duct, and what is A for? A is the aorta. A is the aorta. So as I will zoom now, let us zoom. Once again, what are we looking at? We are actually looking at median arcuate ligament bounded by right crus of diaphragm, left crus of diaphragm. This is median arcuate ligament. It is in front of T12 vertebra, ATA structure. ATA. What is this A? In our body, veins are to the right side embryologically and arteries are to the left side embryologically. So which vein to the right side embryologically? Azygous vein. And which artery to the left side embryologically? Aorta. Which aorta is this? Actually thoracic aorta entering the abdomen. It is the thoracic aorta. It is the thoracic aorta which will enter the abdomen, passing median arcuate ligament. So thoracic aorta is now entering into abdomen, becoming abdominal aorta. Yes. You mean to say descending thoracic aorta will be passing behind the median arcuate ligament to enter the abdomen to become abdominal aorta. Yes. And who is there in the middle? In the middle, this is thoracic duct which will enter the thorax. So that is thoracic duct which will enter the thorax. Actually, thoracic duct begins at T12 vertebra and enters the thorax. What does it do? It will bring the lymphatics of body below diaphragm. So what is below diaphragm? Abdomen, pelvis, lower limb. So lymphatics of lower limb, pelvis and abdomen will be there in thoracic duct, and thoracic duct will carry it towards the neck veins, because all the lymph should drain into neck veins. So you mean to say body below diaphragm, which is abdomen, pelvis, lower limb, lymph will be collected in thoracic duct, and then thoracic duct will enter thorax. Yes. And what it will do? It will go and drain into neck veins. The lymph will be drained into neck veins before the neck veins drain into the heart. So lymphatics must drain into neck veins before the neck veins drain into the heart. Okay, what is this vein here then? This vein, we are not showing it in venous color, but let us show it in venous color. That vein is azygous vein. Azygous vein. So this is azygous vein. Yes. What is the purpose of azygous vein? Azygous vein will collect all the intercostal veins in the thorax. So intercostal veins will drain the thorax into azygous vein, and azygous vein will then drain into superior vena cava. These are all your MCQs, FMGE MCQs. This is one FMGE MCQ. They will be asking you about the azygous vein draining into. See, body above diaphragm drain into superior vena cava, body below diaphragm drain into inferior vena cava. So body above diaphragm drain into superior vena cava means thorax will drain into superior vena cava, means azygous vein will drain into superior vena cava. But body below diaphragm drains into inferior vena cava. Because azygous vein is draining intercostal vein which is thorax, so it should drain into superior vena cava. It was passing here, ATA structures. Now this is about the median arcuate ligament, fine. And we also, you already gave the answer in fact, so I will mark the answer. The answer was obviously thoracic duct, yes. But then what about the other choices? For other choices, we'll come back to this diagram again, but just remember voice of anatomy. Just remember voice of anatomy. Now, what is this voice of anatomy? It is to remember some of the structures which are passing in relation to diaphragm. You are looking from side view. You are looking from side view, and this is the diaphragm. Diaphragm is a skeletal muscle, and it takes origin from sternum bone, ribs, and vertebra. So, diaphragm is a skeletal muscle taking origin from xiphisternum and lower 6 ribs and lumbar vertebra. And what is the insertion? Insertion is into the central tendon. Insertion is into central tendon. I'll show it here. The origin, if you are asking about the origin, let us use the same color. The origin is xiphisternum and the lower 6 ribs and the lumbar vertebra. This is T12, so here lumbar vertebra. So, lumbar vertebra, crura basically, right crus of diaphragm, left crus of diaphragm. So, coming from the lumbar vertebra 1 to 3, you will have crus of diaphragm. Skeletal muscle, so this is the origin. Xiphisternum is the origin, lower 6 rib is the origin. Where is the insertion? Insertion is into the central tendon of diaphragm. This is the insertion. Now, if you say this is the insertion, what is the action? For action, you remember DDD. And what is DDD? The action of diaphragm. Yeah, but what is the full form of DDD? Diaphragm descend down during deep inspiration. So, diaphragm will descend down during deep inspiration. When we take deep inspiration, diaphragm descend down. So, what is the purpose of doing that? See, it is a skeletal muscle. If this is the origin, that is the insertion. When a skeletal muscle is contracting, what will happen to the fibers? They shorten. Origin, insertion. When a skeletal muscle is contracting, muscle fibers shorten. So, when it will shorten, what will happen? Diaphragm descend down. But what is the purpose of descending down? When the diaphragm descend down, there is deep inspiration, the lungs can expand vertically. So, lungs can expand vertically and more air can come, or in deep inspiration, when the lungs are expanding vertically, diaphragm must descend down. It is a chief muscle of inspiration. Diaphragm is the chief muscle of inspiration. So, diaphragm is the chief muscle of inspiration because during inspiration diaphragm descend down. Okay, that is about the origin, insertion, action of diaphragm. What is the nerve supply? Nerve supply is phrenic nerve, C3, C4, C5. So, the nerve supply is phrenic nerve and it is coming from cervical region and supply the diaphragm. Now, somebody might ask, diaphragm is here, why it is getting a cervical nerve 3, 4, 5, phrenic nerve? Because during development diaphragm was here. Embryologically it descends down, carrying the nerves down. So, remember, diaphragm was never here. Then where was diaphragm? It was here. You mean to the diaphragm is developing in the neck region? Yes, embryologically these muscles are cervical myotomes. They are cervical myotomes. So, you mean to say diaphragm come from the neck region? Yes, cervical myotomes. Diaphragm has muscles from the neck region, cervical myotomes. Later it will descend down, but when it descend down, it will carry the nerve also. So, it become a long nerve. Which nerve become long nerve? Phrenic nerve. It passes thorax to reach the diaphragm. Anyhow, which structures are passing? What is this voice of anatomy? Voice of anatomy. So, what is this voice of anatomy? Voice of anatomy, V inferior vena cava, O esophagus and A aorta. So, as we remember the mnemonic, voice of anatomy, V is vena cava, inferior vena cava, and O is esophagus and A is the aorta, which you can see here. You will find that this is the inferior vena cava which is puncturing. See, first of all, you know, body below diaphragm drain into, body below diaphragm drain into, body below diaphragm drain into inferior vena cava, like liver will drain into inferior vena cava because liver is under the diaphragm. So, liver is under the diaphragm, liver will drain into the inferior vena cava. Where the inferior vena cava will drain? Inferior vena cava will drain into the heart, but how it will enter the heart? By puncturing central tendon of diaphragm. So, maybe you had liver here and liver drains into the inferior vena cava under the diaphragm. Now, inferior vena cava enters the right atrium of the heart, but to enter the right atrium of the heart, it has to puncture central tendon of diaphragm. So, here as you can see, we are talking about the inferior vena cava puncturing central tendon of diaphragm to enter the right atrium of the heart. It will puncture the central tendon of diaphragm where? And your answer is T8 vertebra. Then you will see esophagus is in the neck region, then enters the abdomen to become stomach. So, esophagus is in the neck region, thorax region, and then enter the abdomen to become stomach. So, when the esophagus is entering, it is passing through the diaphragm and then it will become stomach, then it will become the stomach, but some part of esophagus is there in the abdomen also. Mostly it is in the thorax and neck region where it is passing. So, esophagus is passing through the diaphragm and it is T10 vertebra level, T10. So, what is happening in front of T12 vertebra? In front of T12 vertebra, we have the ATA structure passing through the median arcuate ligament. So, in front of T12 vertebra, we have the ATA structure passing, and in that ATA structures, one of the structure which you can see here is the aorta. Now, which aorta is this? You know, before this T12 vertebra, it is thoracic vertebra, thoracic aorta, but after that it is lumbar vertebra, so abdominal aorta. It means in front of T12 vertebra, you will see that descending thoracic aorta becomes abdominal aorta. But one thing which you should know is aorta do not pass through diaphragm, it passes behind the diaphragm. The inferior vena cava and esophagus, they puncture the diaphragm. Aorta do not puncture the diaphragm. The inferior vena cava and the esophagus, they puncture the diaphragm, but aorta do not puncture the diaphragm. Or simply a question came, which structures pass posterior to diaphragm? Which structure pass posterior to diaphragm? Your answer is aorta passes posterior to diaphragm. It does not pass through the diaphragm. Then which structure pass through the diaphragm? They are inferior vena cava and esophagus, not the aorta. So, just remember this voice of anatomy, T8 and T8, T10 and T12, T8, 10, 12, just for your purpose, cannot go into much detail here, but if you want to see the openings, we can show them here. This is inferior to superior view. You are in the abdomen looking towards the thorax, and this is the opening for ATA structures bounded by right crust, left crust of diaphragm. Then you will see the right crust of diaphragm is making a loop. Right crust of diaphragm is making a loop, and through that passes esophagus. So, esophagus passes through the right crust of diaphragm. Which vertebra? That is T10, that is T10. So, it will be at T10, this is T10, this was T12. And what is this opening in the central tendon of diaphragm? That is T8 and that is for inferior vena cava. So, these are the openings. Taking too much of time. What is this? What is the answer to this question? Tell me, increase negative pressure in thorax. Correct. When diaphragm descends down, it will increase the negative pressure in thorax. That is how the lungs can expand vertically. Yes, correct. A. No, I am asking about abduction. Medius, yes, medius. Don't say maximus, though maximus can help, but the answer should be, it is abduction. Medius, medius should be the answer. So, as you see, question is asking abduction at the hip joint. If you tell about gluteus maximus, it is the chief extensor muscle at the hip joint, extension. So, gluteus maximus is the chief extensor at the hip joint. It is the gluteus medius which is not only abductor but also medial rotator at the hip joint, ab-MR. Gluteus medius is abductor and medial rotator, and because the gluteus medius is medial rotator, the gluteus maximus can be lateral rotator. Now, when I say it can be lateral rotator, you can mention, but that is not your first answer. Your first answer should always be hip extension. I will repeat again. When you say gluteus maximus, first answer should always be extension at the hip joint, though it is also a lateral rotator at the hip joint, but that is your second answer. Then what is the action of gluteus medius? Gluteus medius is ab-MR. What is that? Abductor and medial rotator. So, you mean to say they antagonize each other? Yes, they antagonize each other if you are talking about medial rotation and lateral rotation. Otherwise, that is not their primary action. Then what is the primary action? Primary action of gluteus maximus is extension at hip joint, and gluteus medius is abduction at the hip joint. Okay. Then what about this obturator, internus and quadratus femoris? First of all, you should know gluteus maximus is a large muscle, and these muscles are under cover of gluteus maximus. If you remove gluteus maximus, then you can see the three of them. So, these three muscles cannot be seen until you remove the gluteus maximus properly. Okay, I have removed, I see these muscles. Now, what do they do? Gluteus medius is medial rotator. Yes, I know. These muscles help the gluteus maximus for lateral rotation, but they are short. So, short lateral rotators. I will repeat again. Once you cut the gluteus maximus, you can see the three muscles, out of which one is medial rotator, but the other two are lateral rotators. They are short lateral rotators. So, they will be helping which muscle? Gluteus maximus, because gluteus maximus can also do lateral rotation. Now, a question comes. Name the lateral rotator at hip joint. Which should be your first answer? Gluteus maximus or these two? Remember, gluteus maximus, the first action is extension. That is an accessory action. Means if somebody asks you lateral rotator, the first answer should be obturator internus, quadratus femoris. So, you mean to say obturator internus, quadratus femoris are lateral rotators at the hip joint? Yes. Gluteus maximus is extensor at the hip joint? Yes. And gluteus medius is abductor medial rotator at the hip joint? Yes. Then who is the adductor at the hip joint? Adductors. You don't have to remember anything. Why? Because their names are adductor brevis, adductor longus, adductor magnus. So, they themselves tell we are adductors. So, when the name is telling, they will definitely be doing adduction. So, adductor brevis, adductor longus, adductor magnus, they are adductors, so they will do adduction. Then who will antagonize them? Who will antagonize them? The gluteus medius, because gluteus medius is abductor. Okay, let us reinforce this. As you are reinforcing it, remember three gluteus muscles, posterior to anterior. Remember three gluteus muscle, posterior to anterior. So, which is the posterior most? You will notice that largest of all is gluteus maximus. The name is telling maximus, maximus. So largest of them gluteus maximus. Until you remove it, you cannot see the one which are deeper. What is the origin of gluteus maximus? It's a skeletal muscle. It will have a bony origin. So it will be taking origin from, say, sacrum bone and the hip bone. So it is taking origin from sacrum bone and hip bone. Now if that is the origin, then where is the insertion? 25% fibers insert on femur, 25% fibers insert on femur at gluteal tuberosity. I'll repeat, gluteus maximus is the largest of all, that is why the name maximus, and it is the posterior most. Origin is sacrum and hip bone, and insertion is 25% fibers in femur, gluteal tuberosity. And what about 75? 75% fibers, they will be descending down and they will insert on tibia. They will insert on tibia. There is a tract which is called as iliotibial tract. Iliotibial tract. So you are telling gluteus maximus muscle insert on tibia bone. Tibia bone, yes. There is a Gerdy tubercle, and that is where it will insert. So you are telling gluteus maximus 75% fibers will be coming to the tibia at Gerdy tubercle, yes, and attaching via what is this? Iliotibial tract. Yes, it is called iliotibial tract because it is coming from ilium bone, hip bone, and attaching to tibia. So iliotibial tract. 75% into tibia, 25% into the femur. What is the action? When the gluteus maximus insert on femur, it can move femur. Yeah, but where it can move femur? See, this is the origin, this is the insertion. Whenever a muscle will contract, it will shorten. So which moves, the origin or insertion? The insertion will move. If insertion will move, where it will move? Insertion will move close to the origin. Which color should we take? Like green only, like this. So if you are telling that when a muscle contract, it will shorten and the insertion will move close to the origin, what will happen to the femur bone? Femur bone will be pulled posterior. Femur pulled posterior. So when femur is pulled posterior, what is this called? When femur is pulled posterior, it is called extension. So gluteus maximus is the chief muscle of extension. Origin, insertion. When the muscle contract, shortens. Insertion move close to origin. Femur will be pulled posterior. If you pull the femur posterior, what is that? That is the hip extension. It is antagonizing a muscle which can pull the femur anterior. Which muscle can pull the femur anterior? It is iliopsoas. What is iliopsoas doing? Hip flexion. So there is a muscle which is called iliopsoas, and it can pull the femur anterior. So if it can pull the femur anterior, what will happen? Hip flexion. So which is the chief muscle of hip flexion? Chief muscle of hip flexion is iliopsoas, and chief muscle of hip extension, gluteus maximus. So they are antagonizing each other? Yes, they are antagonizing each other. Iliopsoas is antagonized by gluteus maximus. This is flexor, that is extensor at the hip joint. Okay. What about the gluteus medius? Gluteus medius takes origin from hip bone and insert on lateral surface of greater trochanter. Lateral surface of greater trochanter. Now, since the gluteus medius muscle take origin from hip bone and insert on lateral surface of greater trochanter. Why I am telling lateral surface of greater trochanter? Because it is already a question where the gluteus medius insert. You say lateral surface of greater trochanter on bone femur. So what it will do? It will contract and pull the femur away from the body. Away from the body. So if the muscle contracts and pull the femur away from body, what is that called? Taking femur away from body is abduction. So it will do abduction, and not only it will do abduction, it will also do medial rotation. And how it will do medial rotation? So gluteus medius is abductor, pulling the femur away from the body, and it is also medial rotator. The fibers are inserted in such way that it is a medial rotator, medial rotator. So the insertion of fiber is such that it will rotate the femur medial, and not only gluteus medius, it is also done by gluteus minimus and tensor fasciae lata, and these three muscles are supplied by a single nerve named superior gluteal nerve. I'll repeat again. Abduction and medial rotation is done by three muscles. Abduction and medial rotation is done by three muscles, namely gluteus medius, gluteus minimus, and tensor fasciae lata. And these three muscles, they are supplied by same nerve. The name of nerve is superior gluteal nerve. So superior gluteal nerve supply three muscles, namely gluteus medius, gluteus minimus, tensor fasciae lata. And what are these muscles doing? Two functions. What is the two function? Abduction and medial rotation. What is the attachment of gluteus minimus? Attachment of gluteus minimus is same as gluteus medius with one difference. Now what is the one difference? What is the origin of gluteus minimus? Hip bone. And what is the insertion of gluteus minimus? The greater trochanter. So what is the difference between the two? This minimus is more anterior, so attaches more anteriorly on greater trochanter. Attaches more anteriorly on greater trochanter. You mean to say, may it be gluteus medius or minimus, origin is hip bone, yes. Insertion is greater trochanter, yes. But this medius attaches to lateral surface of greater trochanter, and this attaches to anterior surface of greater trochanter because it is more anterior, yes. But what is the nerve supply? Nerve supply of gluteus minimus or medius or tensor fasciae lata is superior gluteal nerve. What will happen if superior gluteal nerve is damaged? Your FMGE question. What will happen if superior gluteal nerve is damaged? Polio virus, anterior horn cell damage, L4, 5, S1 compromise. I'll repeat again. Your FMGE question. There is a polio patient, right-sided, superior gluteal nerve is not working. There is a polio patient, right-sided, superior gluteal nerve is not working. Why? Because polio virus has damaged anterior horn cell of the spinal cord number L4, 5, S1, and that is the root value of superior gluteal nerve. You mean to say three muscles will be paralyzed? Yes. In polio virus involvement of anterior horn cell with root value L4, 5, S1, superior gluteal nerve is compromised. Now these muscles are not working. Abductor mechanism is compromised. And if the abductor mechanism is compromised, Trendelenburg test become positive. Trendelenburg test become positive. Sir, what is this Trendelenburg test become positive? This is. So your question is asking, patient, stand on his right foot, left hip falls down, which muscles are affected? FMGE this year. FMGE this year. Lurching gait, correct. D. Very good. Very good. Yes. Ram Kumar? Yes. Raju, Vikas? Yes. Vishnu? Vaishnavi? Yes. Good. Because you know these are very repeated questions, and let us discuss them. But you have answered it perfectly, all right, no issue at all. So, patient was asked to stand on right foot, left hip falls down. Something wrong with right-sided muscles, maybe something wrong with right-sided superior gluteal nerve like polio virus. So right-sided muscles will not be working, namely gluteus medius, gluteus minimus, tensor fascial lata. It is a problem of abductor mechanism. Problem of abductor mechanism. So right-sided, right, and right-sided also not the maximus. It is medius and minimus. So this is your answer. Now let us look at some details which are important for your purpose, and they are here. See, first we should know normal, then we can discuss abnormal. So what is normally happening? Normally, say you are looking from posterior view now on the right gluteal muscles. So looking from the posterior view, right gluteal muscles, namely gluteus medius, gluteus minimus, supplied by right-sided superior gluteal nerve. Now maybe we are discussing on one side, but it works both sides same way. So let us discuss one side, other is understood. Okay, so you are looking at right hip joint, right gluteal region from posterior view, gluteus medius minimus. What do they do? We know what do they do. Superior gluteal nerve supply them, and they are abductors and medial rotators. But first function is abduction. And how do they do the abduction? See, this is the origin, okay, and that is the hip bone, okay, and then we have the insertion, where insertion is on the greater trochanter bone on the femur, okay. So how do they do abduction? They do abduction contraction, means take the femur away. That is their function. Now, of course, when the muscle will contract, it can take the femur away, you can do abduction. But there is a problem. Patient is standing on the ground, foot is fixed to the ground. And when the foot is fixed to the ground, can you move the femur? No, you cannot. So when the foot is fixed to the ground, which is stance leg, you cannot move the femur now, it is fixed. So what will happen? Say you are having a person who is walking, one foot remains on ground, other foot goes into air, which is swing. So swing, when the foot is in the air, the other foot must be on the ground, it is fixed, you cannot move the femur. So what will happen then when this muscle is working? In this scenario, the gluteus medius minimus, because they cannot do abduction, origin insertion will interchange. Origin insertion will interchange. What is that? That means this becomes origin and that becomes insertion. Yeah, okay. This becomes origin, that becomes insertion. What is the purpose of doing that? Insertion will move close to the origin. Insertion will move close to the origin. Okay, fine, but what does that mean? It means the hip bone will be pulled down. Hip bone will be pulled down, but why do you want to pull the hip bone down when the foot is fixed to the ground? Understand, when the other foot is in the air, the gravity is pulling the hip bone down here. So as is understood, during walking, when one foot is in the air, the gravity will pull this pelvis down. You have to balance it from the other side, and that is done by these gluteus medius and minimus if the foot is fixed. So when we are walking, what is happening? One foot goes into air, and what is happening? The gravity will pull the hip bone down. Which hip bone is pulled down? Left side. So left-sided hip bone is pulled down. What is the problem? Problem is you have to counteract the gravity. And how do I do that? You pull the right hip bone down. And how do I pull the right hip bone down? By using these abductor muscles. And what if I have a problem? What is the problem? I have the polio virus on right side. So polio virus on right side means right-sided gluteus are not working? No. If the right-sided gluteus are not working, then you cannot pull the right hip bone down. So left hip bone will be sagging down, lurching gait Trendelenburg test positive. Limb length becomes more. Patient will drag the foot on the ground. Problem is, I have a poliovirus lesion affecting right-sided superior gluteal nerve, affecting right-sided gluteus medius minimus, so that they cannot now pull the right hip bone down. So if you cannot pull the right hip bone down, the left will be over pulled down, and as the left is over pulled down, it will sag down. How the patient will walk? Because now limb length is more and patient will drag his foot on the ground. That is why they develop lurching gait. The spine will bend to the same side of lesion. So they will lurch to the same side of lesion. If right superior gluteal nerve is compromised, if right glutei muscles are not working, then their spine will bend to the same side to clear the left foot off the ground. This is called as lurching gait. They lurch to the same side. So it is right-sided Trendelenburg test positive. Right-sided Trendelenburg test positive. Right-sided glutei muscles not working. Left hip drops down. Left limb length more. Patient drag foot on the ground. To clear the foot off the ground, you have to bend the spine. The lurching is towards the same side of lesion to clear the left foot off the ground. So Trendelenburg test is positive on right side. Now you must be thinking, what is there to so much stress upon? There is. I have seen nobody telling you all this. I have seen people telling you wrong things, and most of you will mark the wrong answer. Sir, why would we mark the wrong answer? I don't know, but I have seen students giving wrong answer. So if I say a patient was asked to stand on right foot, and if the left pelvis drops down, it means right-sided Trendelenburg test is positive. This is the final point I want to tell you. If he stands on right foot and left pelvis drops down, it is right-sided Trendelenburg test positive. Right-sided superior gluteal not working. Right-sided glutei muscles not working. But be careful. Patient will be lurching to right side only to clear the left foot off the ground because it is falling down. Okay? And of course, gluteus medius minimus. And be careful, this is not only a polio patient. It can be fracture neck of femur, Trendelenburg test positive. Even if it is a fracture neck of femur, even then Trendelenburg test can become positive. It can be nerve injury, it can be a fracture, there can be many reasons why the Trendelenburg test becomes positive. Okay, so as we proceed further, you are having this question. Patient presented with difficulty in foot eversion and sensory loss on lateral leg and dorsal foot, the nerve lesion is. I know most of you will try to search for an answer, but that answer is not available. This is your question. It was asked December 2020. What is your answer? Great, very good, very good. So Vihari, Ramkumar, Vishnu, Pranay, somehow Vasit, Altaf, आप ये आंसर डी क्यों लगा रहे हैं? तो ठीक है, गलतियां हमसे ही होती हैं. To err is human, but we have to minimize our mistakes. गलती हर किसी से होती है और हमें अपनी गलतियां कम करते जाना है. देखो, अगर आप ये कहो कि मैं गलती नहीं करता, तो क्या आप भगवान हो? और असल में भगवान भी गलती करते हैं, इंसान बना दिया तो गलती तो करी थी। गलती हर कोई करता है। टू एरर इज ह्यूमन, बट यू आर नॉट ह्यूमंस, यू आर सुपर ह्यूमंस। आप पुरुष नहीं, महापुरुष हैं। और मतलब स्त्री को भी ले लो, महास्त्री हैं आप। तो पुरुष और स्त्री तो आप रहते ही नहीं, आप बन जाते हैं महापुरुष और महास्त्री, क्योंकि आप डॉक्टर हैं। डॉक्टर्स ह्यूमन नहीं होते, दे आर सुपर ह्यूमंस। तो ये फ़र्क क्या हुआ? फ़र्क सिर्फ ये है कि हम गलतियों को कम करते जाते हैं, क्योंकि हमारी गलती हम खुद ही नहीं माफ़ कर सकते। कोई पेशेंट अगर आपके हाथ से निकल रहा हो तब आपको पता चलेगा। तो गलतियां हमें गवारा नहीं। अब किसी ने कहा था इंग्लिश में पढ़ाओ, मैंने इंग्लिश में पढ़ा दिया। But most of the students will try to find for the answer which is common peroneal nerve, but they have not given the answer common peroneal nerve. So if common peroneal nerve is not there, which is clinically relevant, this is more of a hypothetical question. And if it is a hypothetical question, you give hypothetical answer, and hypothetical answer is superficial peroneal nerve. Now, why superficial peroneal nerve? Why not deep peroneal nerve? That is what we want to find out. So here you have to understand that there is a sciatic nerve which runs in the posterior thigh. So there is a sciatic nerve which runs in the posterior thigh, and that sciatic nerve which is running in the posterior thigh, we are projecting it anteriorly, though you cannot see sciatic nerve from the front because it is posterior thigh. So right sciatic nerve. Right sciatic nerve giving two branches posteriorly in the relation of popliteal fossa, which is behind the knee joint. So behind the knee joint you have popliteal fossa, there the sciatic nerve will be giving two branches. We cannot see from the front, we are just projecting it anteriorly. And the right sided sciatic nerve giving you one nerve which go around the neck of fibula, common fibular nerve, which is also called common peroneal nerve, common fibular nerve or common peroneal nerve, and the other branch continues posteriorly in the calf, posterior tibial nerve, because it goes posterior to tibia in the calf. So right sided sciatic nerve in the thigh, posterior thigh, is giving two branches, and there is common peroneal nerve which is also called common fibular nerve, and it is related to the neck of fibula. So you should know it is related to neck of the fibula, and if there is a fracture neck of fibula, this nerve can be damaged. So if there is a fracture neck of fibula, this nerve can be damaged, which is common fibular nerve or common peroneal nerve. Peroneal, fibular is interchangeably used. Now this common is called common because it divides into two. So what are the two branches it will give? It divides into two. One is anterior tibial nerve because it goes anterior to tibia, which is also called deep peroneal nerve. So common peroneal nerve will divide into two. One will go anterior to tibia, which is anterior tibial nerve, also called deep peroneal nerve, and the other is going laterally, and it is called superficial peroneal nerve. So you are now having common peroneal nerve, the name common because it divides into superficial and deep branch. The deep branch is deep peroneal nerve or anterior tibial nerve, the superficial branch is superficial peroneal nerve. Now superficial peroneal nerve is going laterally, it will supply two lateral leg muscles. The two lateral leg muscles are peroneus longus, peroneus brevis, and peroneus longus, peroneus brevis will turn the sole lateral. Turn the sole lateral means foot eversion, foot eversion, eversion. Turn the sole lateral. I repeat, the common peroneal nerve, the common peroneal nerve gave a branch, superficial peroneal nerve. Superficial peroneal nerve is supplying two muscles in the lateral leg compartment. Superficial peroneal nerve is supplying two muscles in the lateral leg compartment, namely the peroneus longus and peroneus brevis. They turn the sole lateral. So there are two everters, eversion at subtalar joint. eversion at subtalar because it is under talus bone, under talus, subtalar. So at the subtalar joint you will have sole turning lateral eversion. So what are the two everters? They are peroneus longus brevis. What are they supplied by? Superficial peroneal nerve. What if I damage it? If you damage the superficial peroneal nerve, there will be a loss of foot eversion. That was the question. But then the superficial peroneal nerve is supplying skin also. It supplies skin on the most of the dorsum of the foot. So most of the dorsum of the foot, is supplied by superficial peroneal nerve. It also supplies lateral surface of the leg. So lateral leg region also. I'll repeat. Most of the dorsum of the foot is supplied by superficial peroneal nerve. It also supplies lateral leg compartment, skin. So the point is, if superficial peroneal nerve is gone, number one, muscles paralyzed, peroneus longus brevis, loss of eversion at the subtalar joint, plus sensory loss, lateral leg skin and dorsum of the foot, most of it. But then except first web space, because the first web space is supplied by a separate nerve. And what is that nerve which supply the first web space? Deep peroneal nerve or deep fibular nerve. Dermatome L5, dermatome L5, great toe L5, great toe is L5. So great toe is L5. The dorsum of first web space, is not supplied by superficial peroneal nerve. Then who is supplying dorsum of the first web space? The great toe area. Deep peroneal nerve. Which deep peroneal nerve? This one. So this deep peroneal nerve, as you are showing, what else does it supply? So deep peroneal nerve, which is also called as anterior tibial nerve, deep peroneal nerve is having root value L5. L5 is for dorsiflexion ankle, So at the ankle you can do dorsiflexion. How can I do dorsiflexion? By L5. Yeah, but which muscle? That is extension at the ankle. So muscles will be extensor. Yeah, which extensor? The anterior tibial nerve or deep peroneal nerve supply extensor, Tom, Dick and Harry. Extensor, Tom, Dick and Harry. And who is this extensor, Tom, Dick and Harry? The Tom is tibialis anterior, lying anterior to tibia, supplied by anterior tibial nerve, also called deep peroneal nerve. So extensor, Tom, Dick and Harry. The Tom is tibialis anterior. And what about the others? Extensor digitorum longus, extensor hallucis longus. So let me zoom this area now and you can see what we are talking about. We are talking about this nerve. Who is this? It's a branch of common peroneal, name deep peroneal nerve. What does it do? Deep peroneal nerve, also called anterior tibial nerve, because running anterior to tibia and supplying the extensor Tom, Dick and Harry. The Tom is tibialis anterior and extensor digitorum longus to extend the toes and extensor hallucis longus to extend the great toe, but extend. What will happen if I damage it? If you damage it, loss of extension. Loss of extension means loss of dorsiflexion. Foot drop? Yes, foot drop. So injury of anterior tibial nerve, which is also called deep peroneal nerve, there will be a foot drop, loss of dorsiflexion plus sensory loss. Where? Dorsum of the first web space. So remember, dorsum of the first web space, sensory loss is because of deep peroneal nerve, dermatome L5. Lastly, you should know the four nerves supplying dorsum of the foot, laterally sural nerve, medially saphenous nerve, laterally sural nerve, most of the dorsum, superficial peroneal nerve, and dorsum of the first web space, deep peroneal nerve. To remember, we can draw a simple diagram. Look at the dorsum of the right foot. This is the midline of the body, and look at the dorsum of the right foot. Now if this is the dorsum of the right foot, four nerves supply skin here. You can show this is great toe and this is little toe. So, you are showing the great toe and little toe now. Yes, little toe laterally, great toe medially. And then you should tell the saphenous nerve, this is sural nerve. So, sural nerve, let me take this little bit to this side. You will see that the little toe and lateral margin on dorsum of the foot is supplied by the sural nerve, and sural nerve is a branch of posterior tibial nerve. And what is the dermatome? S1, S1. I will repeat. This is dorsum of the foot supplied by 4 nerves. Little toe lateral margin on the dorsum of the foot is supplied by sural nerve, branch of posterior tibial nerve. Dermatome S1. If there is a slip disc at L5 S1, if there is a slip disc at L5 S1, S1 nerve is compromised and burning sensation little toe, because sural nerve is compromised. So, slip disc where? L5 S1 will compress which nerve? S1. And where will be the burning sensation? Little toe lateral margin. Why? Because sural nerve branch of posterior tibial nerve is compromised. And what if I have done great saphenous vein extraction and damage the saphenous nerve? What if I have done great saphenous vein extraction and damage the saphenous nerve? Then saphenous nerve territory is here. This is saphenous nerve territory, but it does not reach the great toe. It does not reach the great toe, and this is L4 dermatome. Great toe is L5, be careful. Great toe is L5. So, you are telling when we are doing great saphenous vein, venous section, maybe for varicose vein or cardiac surgeries, CABG, coronary artery bypass graft. I was operating on a patient, CABG, coronary artery bypass graft, or maybe I had a patient of varicose vein and I remove great saphenous vein. But as I remove great saphenous vein, I have damaged saphenous nerve. Where will be the sensory problem? Sensory problem, dorsum of the foot medially. This is medially. And which dermatome? L4. Why L4? Because saphenous nerve is a branch of femoral nerve, and femoral nerve give which value to the saphenous nerve? L4. So, femoral nerve give you the saphenous nerve which was damaged, and it has dermatome L4, and there will be sensory loss on the dorsum of the foot medially, but not the great toe, not the great toe. Why? Who is supplying the great toe? Most of the dorsum of the foot is supplied by cervical peroneal nerve, except the dorsum of the first web space, because that is supplied by deep peroneal nerve. So, there are 4 nerves supplying dorsum of the foot. Saphenous nerve do not supply great toe. Okay, who is supplying? The deep peroneal nerve and cervical peroneal nerve. Now, deep peroneal nerve is supplying which part of great toe? Lateral part of great toe. And which nerve supply medial part then? Cervical peroneal nerve. Superficial peroneal nerve supply most of the skin on the dorsum of the foot, including medial side of great toe. Is a question. Question was, medial side of great toe is supplied by? Question was, medial side of great toe is supplied by? Your answer is superficial peroneal nerve. Next time question can come, lateral side of great toe is supplied by? You say lateral side of great toe is supplied by deep peroneal nerve. Is the saphenous nerve supplying great toe? No. No. Okay. So, let us go back to this question. What is the answer? You already have answered, and your answer is patient presenting with difficulty foot eversion, turning outside laterally, lateral leg muscle, peroneus longus brevis. So, peroneus longus brevis and sensory loss on lateral leg and dorsum of the foot. Dorsum of the foot, because most of the dorsum of the foot is supplied by superficial peroneal nerve. That is your answer. Why? Where is this sural nerve supplying? Sural nerve is a branch of posterior nerve. It will supply little toe and lateral margin of the foot. And what about saphenous? Saphenous nerve is a branch of femoral nerve. It has L4 dermatome and it will supply dorsum of the foot except the great toe. Why we will supply great toe? Skin. Great toe skin is supplied by deep peroneal nerve L5 but laterally. If it is supply lateral great toe, then who will supply the medial great toe? Medial great toe is supplied by superficial peroneal nerve. Root value is L5 only because great toe is L5 only, but it will supply medial great toe. Medial great toe, and great toe is not supplied by the saphenous nerve. Okay. So my point is minimize your mistakes. 7:13. Okay. Tomorrow's session means tomorrow and day after tomorrow is ENT. Dr. Vaishnavi will be joining you. She will be taking care of ENT session 1, session 2, and starting 5 p.m. just like anatomy. And one thing I have to say, like and subscribe, which I normally don't. Now somebody might ask, why like and subscribe? I have a logic. The logic is YouTube logistics work in that way. If you like and subscribe, then the information will reach more and more of the fraternity, medical fraternity, and we are lucky if we can reach more and more people, so that more and more people can benefit from this sharing of knowledge. So like and subscribe. That was the instruction given to me, so I followed the instruction. So thank you very much, and thank you for giving us the opportunity to stand in front of you to share some knowledge which we have gained through our long experience of being in medical field. I belong to 93 batch. I started my first MBBS in year 93. It's 23 now, 30 years. But good thing is, we were so enthusiastic that when I teach you such things, I haven't forgotten my dissection on my cadaver, on my table till this date. It is imprinted. Though I never thought that I will become an anatomy teacher. Of course, nobody joins MBBS to become a teacher. People join it because they want to become a surgeon or physician, but life is unpredictable. Wherever you are, be satisfied and do the best possible. Okay? And by my inherent nature, I am a physician, I am a surgeon. Even if right now you give me a case, my mind will start working the same way as it used to work when I did my practice maybe 2-3 years. After that I stopped. So point is, be a good doctor, okay? And we are there to help you out. Take care. All the best.